Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. My name is Joe Ceramelli, and I have overseen the Grand Rounds for our department. Today is the last Grand Rounds presentation of this academic year. It's a very interesting and I think appealing final presentation for the year, which we can get into in a moment. But first, I want to say just a couple of things about this Grand Round series, or about for this year. There is a group of us, an evolving group over the course of this year that works on Grand Rounds each week and throughout the academic year, including Semhar and Annalie. And we do record and archive all of the presentations for Grand Rounds, which are on the department website under the education section. There's a couple of sources of funding for this year's series, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, and the Treatment of Mood Disorders Fund. Now, for today's presentation, I encourage people to write in comments or questions throughout the three different presentations. It's a little bit different today. We have three separate presentations highlighting the results of projects that were completed by trainees participating in the Clinician Scientist Training Program. And that's one project by Yanni Cheng and Adam Ketron, one project by Daniel Fisher, and one project by Nico Park, all of whom were mentored by faculty in the department. So we'll start off hearing about this Clinician Scientist Training Program from Jesse Fan. I'll stop sharing and we'll go from there. Jesse, you're on mute.
Great, thanks for telling me. Hi, everybody. Thanks for joining. Thanks, Joe, for including us in your Grand Round series. I'm Jesse Fan. I'm a professor here in the Department of Psychiatry and director of the Clinician Scientist Training Program. I'm just going to speak very briefly to give you a little background about the Clinician Scientist Training Program and really want to turn it over to our wonderful trainees and their description of their projects. So we developed the Clinician Scientist Training Program a little over a year ago now with the rationale that we strongly believe that the clinician who is also able to do research is particularly well positioned to develop clinically important research questions and testable hypotheses that can, once the discoveries are developed and innovated, they can translate the research discoveries back into clinical practice. And we feel strongly that this cycle is critical in continuing to advance psychiatric research and clinical care. Unfortunately, this is just a graph that indicates the number of people applying for loan repayment programs. That's an indicator for people going into research, and that there's a steady decline among both PhD and MD recipients who are going into clinical research. And so we developed the Clinician Scientist Training Program to really help develop clinician scientists by identifying and engaging and supporting students, trainees, and early career faculty who are interested in research. And this is funded by generous funds from the Garvey Institute for Brain Health Solutions, the Wayne Caton Memorial Fund, and other supports from the department, and is skillfully managed by Andy Uemoto in our department. So you can look at the different strategies, which are really, we have a multimodal array of strategies to try to achieve our mission. But today I want to really emphasize this one right here, which is to develop opportunities to help support our trainees in engaging in research during their training, and also to help support mentors in helping our trainees do their research during their training programs. You can look on our website to look at some of our other strategies that we're engaged in. So today, I just want to give you some background on our trainee research awards. They're one-year grants up to $25,000 that trainees who are second, third, or fourth year psychiatry residents, psychology interns, or fellows who are also engaged in clinical care can apply for. And they're paired up with a faculty mentor from our department, and our mentors can be supported for up to 5% of their FTE. Other mentors from within or outside the department are also encouraged to be involved as appropriate. So we, in our first year, we're happy to fund 10 outstanding projects. You see the trainees here who are funded and their mentors who are involved with their projects. We have 3 of our projects highlighted today with their mentors also attending. This is a snapshot of the diversity of projects that were funded, ranging from basic science to technology studies to epidemiologic studies to quality improvement studies. So really a diverse, wonderful array of projects. And we're just highlighting these 3 here to show you, the diversity and some of the really interesting results that have come out of the projects. So I'm going to stop here and turn it over to our first couple of speakers, which I believe are Dr. Chang and Dr. Kitron.
And I think I was going to give a quick introduction of Adam and Yanni before they jumped in, if that's okay.
Please do. Yeah, Dr. Hallgren.
Great. Happy to be here. Thank you all. And thanks for being here, everybody in the audience. So Adam Kitron and Yanni Chang are about to present to you. They are co-presenting on the dynamic care study experiences from patients and clinicians with a single-arm pilot study of a digital health-based contingency management program that was piloted at several UW medicine clinics. The original pilot was funded by the Garvey Institute for Brain Health Solutions, and Adam and Yanni both co-applied and received, as principal investigators, a clinician scientist training program grant this past year to perform qualitative analyses of input provided by patients and clinicians. It's been really fun to work with them and see them grow along the way, going from folks who are just learning about or are kind of like dipping their toes in this new kind of digital health research for contingency management into fully understanding clinician and patient-facing barriers of how this technology could work and not work for them in desirable ways. Adam is currently a 4th-year resident in our program. He is an incoming fellow of consultation liaison psychiatry and psycho-oncology at Brigham and Women's Hospital and Dana-Farber Cancer Institute. Yanni Chang is an incoming 4th-year resident, finishing up her 3rd year of residency, and she's on the research track, doing research on digital health interventions like this dynamic care project, as well as alcohol screening and suicide risk identification in primary care settings. They have done a terrific job with this work. They have independently coded dozens of transcripts, probably about 40 or 50 total, which is a ton of work for anybody who's done that kind of thing. They've worked really independently and increasingly worked independently as well as in collaboration with each other. It's like those two things seem like an oxymoron to both be happening at the same time, but their independence and collaboration has just grown over the past year together. They presented this at the American Academy for Addiction Psychiatry, and they also presented it at the Resident Research Day this past year and were voted Best Presentation Award by their peers. So I know we're all going to be really enjoying watching you talk. Adam and Yanni, if you'd like to take it away.
Great. Thank you so much, Kevin, for that lovely introduction. So without much to do, I'll just jump into it. Hi, everyone. Adam and I, are super excited to present our study looking at mobile health contingency management for patients with methamphetamine use disorder, and as a qualitative study of both patients and clinician experiences. Next slide, please. So first of all, I want to provide some context for why we chose to do the study and why it's super important. So as we have all undoubtedly experienced in our clinical practice, in our daily lives, in our environment, the United States, our society is experiencing a rapidly escalating methamphetamine use disorder. Here in the US, half the people who use meth meet diagnostic criteria for a use disorder, but less than a third of them receive substance-related treatment. And given its significant public health impact and the fact that there aren't many treatment options available, we need to be expanding existing evidence-based treatments. Next slide. So contingency management is a well-studied treatment for meth use. For people who are not as familiar with it, CM, contingency management, or CM for short, it's a behavioral therapy in which people are rewarded, oftentimes financially with money, for evidence of positive behavioral change. And it's based on principles of basic behavioral analysis. So if we were to reinforce a behavior soon after that behavior is done, we'll increase its frequency. Sorry, give me 1 second. Okay, sorry about that. So basically, contingency management, despite the vast amounts of empirical evidence showing that it's effective and it's efficacious, we have very limited access to in-person contingency management options. So we tested implementation of a digital remote smartphone-based CM program at UW Medicine clinics, hoping that we could offer it in a way that's more accessible for people who need it. Next slide. So in 2023, we published a study looking at the feasibility, engagement, and usability of a remote contingency management program for patients who use methamphetamine in the UW Medicine system. It was a single-arm intervention, like Dr. Halgren has mentioned, of 28 patients, most of whom had self-reported symptoms consistent with severe meth use disorder, co-occurring mental health disorders. The study showed that a fully remote CM program can be delivered within healthcare settings, but participants' engagements with the program varied quite a bit. So once patients were enrolled, they would interact with the application. Here you can see some activities that they could see, like completing CBT modules, meeting with coaches. Saliva tests would then get mailed to their addresses, and they would be asked to take these tests on video camera. And if the test showed that they were absent from methamphetamine, then they would get money loaded onto their debit card. And that's, you see a picture there too. Next slide. So for a CM program to work, we know that it has to work for both patients and the clinicians. And if the patients don't like it, they likely won't engage with it. If the program doesn't really fit well within the clinical system, clinicians likely won't also use it and won't be likely to be offering it to their patients. So for our study, we wanted to get unique perspectives from both of these key stakeholders. And by conducting qualitative analyses of both patients and clinicians, our first aim was to get a better sense of the facilitators, as well as the barriers that they had with the CM program. We also wanted to identify potential ways for this contingency management intervention and its delivery to be improved on and optimized in the future. So next, Adam is going to go into a little bit more detail about the steps we did for the analysis.
Thanks, Yanni. Yeah, so just to talk a little bit about our methods and our coding procedures. At the midpoint of the pilot study, patients and clinicians were invited to be interviewed about their experience and perspectives of the intervention. Half of the patients in the study, so 14 of them, as well as 13 clinicians who were either involved in their care in other ways, or referred them, or were kind of tracking their progress, that were all interviewed. Those interviews were transcribed. And then the study that Yanni and I have been working together on for the past year is a qualitative analysis of those interview transcripts using a systematic iterative approach based on grounded theory. And I have the 5 steps listed here on this slide. So just kind of go through them briefly. Step 1 is just to read through the transcripts and apply analytic memos, which are like informal notes that just come to mind as you read the data. Step 2 was to compile those memos and to develop a code book, which are like each code is a short description of a point being made or a participant's thought about something, and then we just compile all of those codes into a code book that we can refer back to later. Step 3 is to then apply those codes to segments or excerpts from the transcripts. And we used a software called Deduce, which is great for organizing qualitative analysis data and keeping track of everything. Step 4 was to then group the coded textments by each code and write a narrative summary to reduce the data for descriptive results. So here are all the codes or all the excerpts that had this code applied to them. What do they all have in common? How can we kind of reduce them to one or two sentences? And then step 5 is to generate themes by engaging with the data and finding connections. So the team, the 3 of us, will just meet and chat about what we're seeing in the data, finding thematic connections, and then using those to come up with conclusions about the data, think about ways we can improve the intervention in the future. So the next few slides, I'll just present some of the codes that we developed. I won't go through all of them, but just want to focus in on a few that make a few more salient points, and I have those highlighted here. So in terms of the patient's perspectives of things that worked, the facilitators, a lot of patients, as you might imagine, found the financial incentives to be really positive, a reason to want to be in the study, a benefit to their daily life. Some people said, this actually kind of became my primary source of income during the study. A lot of them found that they were efficiently delivered, which, as we know for contingency management, is really important, that temporal association of the reward to the behavior. And several did find that they were of adequate value. Patients also had a lot of good things to say about the drug tests themselves, like having a good feeling about passing the test. Some actually kind of found an extra benefit that they were able to tell from taking the test, oh, there was fentanyl in this substance that I didn't know was there. So they had that added benefit. They really appreciated the randomness of the test prompts, which gave them a certain level of accountability, and they liked having like a window of time to complete the test. So they would get a prompt from the app to complete the test, and then they would need to perform the test on video and upload it to the app to get their incentive. And also just wanted to highlight too that a lot of patients found, despite this being a remote intervention, a lot of them found a sense of human connection and felt like they were really connected to the recovery coach and the dynamic care staff. So just wanted to highlight that part here. Moving on to the barriers that patients found. Actually, I have sort of the mirror image of one things we just saw on the previous slide. Some patients had some negative opinions about the drug tests. They felt that they were inaccurate, they were inconsistent. They really, really did not like that you had to have the test kit with you all the time. So if they had the prompt and they were, at work, or they were, out traveling on the road and they'd left the kids at home, well, then they couldn't complete the test, so they felt like they were missing out on that. A lot of them had some technical difficulties with performing the test or recording the video, and so those were commented on. And oftentimes they would run out of test supplies too fast, and it took too long to replace them. The financial incentives also, some patients thought that they were not quite enough to motivate them to actually engage and stay engaged with the program. So that was noted by a few patients. And then sort of the counterpoint to the last point on the previous slide, a lot of patients actually did not like that it was remote, and they actually preferred the ability to kind of be in person treatment. And so they did make note of that as well. And then I just want to go over some of the recommendations that patients made for how we could improve the program. They really had some suggestions about the drug test kits, that make them smaller, make them easier to use, make them more modern. They were like, this feels like from 20 years ago. They had some suggestions for how we might get those test kits replaced more quickly, like maybe incorporate a feature into the app where they could request it that way. I think some patients didn't realize that they could actually change a setting for there to be a greater allowance of time. So some patients asked for that. They also, of course, as you might imagine, some people suggested increasing the financial incentives for completing the drug tests or the CBT modules. And they also had a lot of things to say about how we might introduce the program to other patients. And the one thing I want to point out here is the last one. Someone pointed out, I only knew about this because I go to the doctor, my doctor told me about it, but I know lots of people in my community who don't see the doctor, and they would have no way of knowing about this. So maybe develop some sort of an outreach program for people not actively or already engaged in the healthcare system. And then finally, I just want to read a couple of excerpts for you to give you a sense of, what patients were saying. No matter the reward, big or small, it feels really good to complete something and have the app notify you. Congratulations, you passed. Here's the reward for you. Those little wins mean a lot. I wasn't expecting that level of support from this. And I think it could integrate better with the addictions clinic here. I know they get copies of everything I'm doing, but they don't mention it. If there was more person-to-person accountability, I think that would help. Right now, I'll turn it back over to Yanni to talk about the clinician perspectives.
Yeah, thank you, Adam. So similar to the patient perspectives that Adam just shared, we also found a number of themes from the clinician interviews, and we don't have time to go over all of them, but I want to just also highlight a couple of them for you. Almost all of the clinicians we interviewed described a strong desire to address the current use treatment gap. They reported a sense of desperation for more tools to deal with the crisis and to help their patients better cope with issues. Many of them also stressed that having a CM program for their patients was helpful and that it allowed them to provide treatment that was aligned with their patients' recovery goals. So some of them liked that this program allowed patients to make some money while engaging in positive behavioral change. And last but not least, they were really glad that the program was very self-sufficient and didn't depend on clinicians to operate or function and didn't add too much admin or clinical burden to them. So next slide. Clinicians also brought up a number of barriers, just to bring your attention to a couple. They were concerned about their patients who were socially limited, for example, being homeless, and therefore wouldn't have the bandwidth to engage with the CM program. Consequently, they were also concerned about equity issues with regards to offering and being involved in the CM program. For example, how would they offer this treatment equitably for their patients, specifically the patients who were historically very difficult to treat, difficult to engage with, and would clinicians be less inclined to get these patients other treatments just because they could access CM more easily? While clinicians liked not being too involved with the CM program, they also noticed that there was a downside of having the program being disconnected to their office visits. And some of them also questioned the ethics of for-profit companies giving out psychosocial treatments. Next slide. In terms of recommendations for implementation, it was really important for clinicians to not feel overburdened, but also have the clinical visits be more aligned with the CM program content as well as timeline. Most of the clinicians wanted to create some kind of a panel, some way of tracking, monitoring, and supporting their patients who were involved in the CM program. And it was also important for clinicians that there are CM programs that are not purely abstinence-based, but more recovery-focused. And so I see that we've got a question in there in the chat, and to have the CM program integrated into the existing workflow. And next slide. So here are two sample quotes from the clinicians. One person said, a lot of patients that we have multiple co-occurring issues, chronic diseases, other medical issues, multiple substance use, mental health diagnoses across the spectrum, which definitely makes for a very challenging population to reach. Another person said, we see this as a problem for our patients. We really want to do something about it. And if this contingency management is a trigger we would pull it, but really kind of ensuring that it's aligned with the patient's own goals.
So I'm sorry to interrupt. We have about 30 seconds left, maybe for and then we'll need to move on.
Got it. So just had a couple of themes there. I think we've already discussed on, so no need to really reiterate those too strongly, but just to kind of go over some things we've done. Like Dr. Hogren mentioned, we presented at AAAP. We were working on a manuscript to be published in a peer-reviewed journal, just kind of finishing up some of the last-minute group discussions on the themes and bringing everything together.
Yep. Last but not least, this is super important. We want to thank the patients and clinicians for helping us have this information to do research on. We want to thank the original contingency management program, Dynamic Care. Some of them are actually here, including Drs. Duncan, Matt Shi, and Andy Saxon. And last but not least, we really want to thank the CSTP for funding our research. Thank you all.
Thank you. Okay, very good. Thank you, Dr. Kitron, Dr. Chang, and Dr. Park. I am encouraging you to get set up here and get ready for the next presentation. And I'll say here we have a transition moment. If there's questions, we'll try to take questions at the end. And I will sort of give my time over to Dr. Park to take on, I think, what would be an interesting description of a secondary analysis from a clinical trial. Thank you.
Yeah, thank
Dr.
you.
Park.
I just need 30 seconds to get set up with the right screen.
While Dr. Park's doing that, I want to thank Dr. Ceramelli for being the primary mentor for this project. I know, Joe, you didn't want to spend much time talking, but just want to thank you for your important mentorship.
Okay, sorry, can you see the main screen or the presenter?
No, we see the field and mountains.
Okay, sorry. Do you see the presenter view?
We just see a desktop.
Oh, okay. Give me 1 second.
Oh, there we go.
Okay, and that's the main view. Okay, well, originally I had some presenter notes that I was going to follow along with, but can't seem to load that right now, so I'll relatively wing it. So my title, I'm Nicola Park. I'm a 4th-year psychiatry resident at the UW, and my project was generally understanding sleep's role in mediating psychiatric management in a rural outpatient setting. And specifically for this project, it developed into looking more into the roles between sleep, CPT, and PTSD, and the associations between those and how they all interact. So I actually wanted to start with acknowledgements. I don't know if that's typical, but starting with Joe Caramelli, who's been a mentor to me in the last 2 years. I thank him partially for helping me even decide to go into sleep medicine, which I'm going to do this summer because his specialty is in bipolar disorder. And the more we got talking, the more I actually kept harping on the sleep variable and looking at sleep studies. So I actually do thank a lot of, our conversations and formulating this project idea and helping me elucidate my clinical goals. And then Jesse Fan for encouraging me to pursue this project and encouraging me to apply for the CSTB grant in the first place, as well as Andy for, helping coordinate everything in both CSTP grant wise. So thanks so much. I wanted to shout out to Brittany Blanchard, Rue, and Aaron, who are part of the population health analytics team, without whom I really could not have done this project on my own, and are statistical whizzes. So thank you so much. Rebecca Hendrickson has been a really amazing resource and co-author on this paper. John Fortney and Deb Kaysen were part of the SPIRIT trial, whose data we utilized and have been pivotal in helping us recreate this project too. And then lastly, the CSTP grant as well. So in terms of background on just PTSD prevalence, as well as the guidelines around sleep problems and PTSD. First of all, the prevalence of PTSD generally in the American populations among adults is around 3.5%. In the VA population, those who utilize the VA healthcare system are estimated to have a prevalence of 11% of PTSD. And then those numbers are actually estimated to be higher in primary care, so at 12.5%. And in a recent study in the last few years, in the FQHC population, this is actually thought to be even higher than that at 23% in one particular study. So there is definitely a significant burden of PTSD in the the populations we work with. In the last couple of decades, sleep is thought to be more of a core feature or a hallmark feature of PTSD, rather than a secondary symptom. So this can include, predominantly insomnia, but also things like night terrors, phobias around sleep, dream enactments, and things like other symptoms that are not just restricted to insomnia. And sleep is also thought to be not just a secondary symptom, but also something where if there is higher sleep disturbance prior to or at the time of trauma, that's actually predictive for the development of PTSD after a traumatic event. So it can be a potent mediator, and also even after PTSD is treated quote unquote adequately in some studies, there are some significant residual sleep problems even after treatment. So a persistent symptom over time. Currently, the VA guidelines, updated as recently as 2023, recommend psychotherapy, so cognitive processing therapy, prolonged exposure, EMDR, as first line, in addition to pharmacotherapy like the SSRIs and SNRI class. But there's no current specification for sleep treatment or sleep intervention as a first line treatment for PTSD, despite evidence that that it is quite an important part of a disease severity and duration. So I thought that was interesting that current guidelines don't really focus on sleep intervention as a first line treatment. And I guess as Joe and I talked about this project, we're wondering if it should be, like if there should be an earlier intervention for sleep problems and PTSD. So the two questions that that came up just in formulating this project was does baseline sleep quality predict PTSD symptom course? In our case, in our data set, we had data on cognitive processing therapy. So that's what that's the kind of therapy that we studied. And then the second question was, does sleep quality improve over time with trauma-focused therapy and CPT? So if the theory is that there's a bidirectional relationship between sleep quality and PTSD outcomes, and can we find in our data set like which like whether the bidirectional relationship is reflected. And these questions were also informed by a 2021 study at the VA with a small cohort of veterans with TBI who actually had they found that higher baseline levels of sleep disturbance actually predicted their response to cognitive processing therapy. So I thought that was a very potent finding, and we were wondering if we could replicate that in our study as well. So background on the data set that we used, we drew primarily from the study to promote innovation in rural integrated telepsychiatry, or the SPIRIT trial. This was done by a group at UW with Deb Keeson and John Fortney. And it was essentially a collaborative care study comparing participants in two arms. So one being the collaborative care arm, where people receive what we understand as the collaborative care model, and then another arm where people saw an individual psychiatrist or psychologist, and then were offered CPT in that arm specifically. The study was across 12 FQHCs across 3 states and included 1,004 adult participants. So the study's main finding was like collaborative care works like substantially, and just as well as the enhanced referral arm. But we focus less on the collaborative care and more on just the measurements that the study also incidentally recorded of the PCL5 and the PSQI scores across the time points of 0, 6, and 12 months. So the PCL5, as many of you know, is primarily a questionnaire for trauma, and then the Pittsburgh Sleep Quality Index, or PSQI, is primarily a metric for sleep disturbance. And then the pathological scores for PCL5 are like between 31 and up, are probable likely PTSD, and then for the PSQI, greater than 5 is considered a significant or pathological score. So briefly, in terms of our methods, we primarily focused on these two variables of the PCL5 and the PSQI, and then we divided the participants in the TER, so the enhanced referral arm, among which there were 227 participants, into 3 groups. So the first group receiving no CPT, the second group receiving 1 to 7 sessions, and the third group receiving 8+ sessions. We used the 2-level mixed models strategy to analyze our data. And so essentially our priority was analyzing the interactions within each CPT group over time, and comparing the PCL5 scores and PSQI scores over time. And then we did an additional analysis of the 2 questions on the PCL5 related to trauma-related sleep disturbance. So briefly, in terms of our main results, so this one has to do with our first question, which is the change in PCL5 score over time based on what the baseline PSQI score was. I highlighted all of these, even though all groups, even though the latter two columns are not statistically significant, just to emphasize that we did not see a relationship between high baseline sleep disturbance as measured by the PSQI on the CPT on the two groups that did receive any level of CPT. But we did notice a statistically significant finding that PCL scores dropped somewhat, but significantly in the group that received no CPT. And in discussions with the PHAT team, we deemed that this was likely not clinically significant because it doesn't really quite make sense that if you had a worse baseline sleep disturbance, your PCL score would get better. Rather, it's more likely that the effect that we saw at baseline between or the association between baseline PSKI and PCL5 at baseline had a weaker association over time at the 6 and 12-month time points. This is addressing the second question, which was how do the PSKI scores change after people receive cognitive processing therapy? So again, I highlighted the 3 columns to show that all of the groups found a statistically significant decrease in PSKI scores at 12 months. And then the group that received 8+ CPT sessions did see the most significant change in PSKI score over time, like the magnitude was the greatest. So what we concluded from these findings was that the 8+ CPT group did meet the minimal clinically important difference, meaning that, okay, this may be clinically, we may see clinical changes, but at the same time, when we look at the actual numbers, like a 2 to 4 point difference over time is still leaving the end PSKI score at 12 months as a pathologically high at pathologically high scores, because the kind of what's considered pathological is again around 5. So we concluded that baseline sleep quality did not moderate CPT effect in our particular population, and then 2, that sleep quality and trauma-related sleep symptoms improved most among those who received like what's considered an adequate dose or full dose of CPT. The overall, that magnitude was small, and it's likely that we still need to figure out or focus on sleep interventions separate from trauma-focused therapy for people who have sleep disturbance related to PTSD. So as of now, I guess for clinical applications too, there isn't a robust reason that CPT or trauma-focused therapy should be deferred for sleep treatment. So for example, if you're deciding to do CPT with the patient, but then they're also referred to sleep medicine for OSA evaluation, there's no need to defer the CPT to optimize, the improvements from CPT that they would get. Significant limitations of our study was we didn't account for other parts of the treatment course, such as sedative medications, diagnosis or treatment of sleep-disordered breathing, or the substance use data. And then participants were not randomized on the variable of sleep quality and trauma chronicity, just by nature of this being a secondary analysis. Future directions in terms of this question could be the application of CBT for insomnia or hypnosis as an integrated therapies with trauma-focused therapies, and that's what the literature reflects these days in experimenting with hybrid approaches. So I think I'm at about time. Yeah, next steps, I'm going to fellowship for sleep medicine, and then we're finalizing the manuscript and doing some final analyses with the PHAT team, a few of whom are actually here today. So thanks for coming.
Thank you, Dr. Park. And interesting results. And what an opportunity to work together over the course of this year and the prior year. Thank you for presenting today. I see Dr. Fisher is present for the next presentation. We're getting down to 12:43 p.m. I think we should move forward, and we'll bring some questions in at the end if we have some time.
And Michael, do you
Okay.
want to say a word?
Yes, I'm Michael Schrift, it's my great pleasure to introduce Dr. Daniel Fisher to give this talk. I know Danny since he received his MD and PhD at Northwestern University Feinberg School of Medicine, where he studied active and passive coping mechanisms related to a particular ion channel in the dorsal hippocampus, the HCN channel, sodium potassium channel. And Danny worked with me at Northwestern in my neuropsychiatry clinic in its 4th year of his clerkship. So even at that time, he had a very strong interest in neurodegenerative disorders and the neuropsychiatric manifestations of those illnesses. And that interest has continued through his training here at UW. Now he's on the Alzheimer's disease training program at T32, where he continues to study the molecular and cellular mechanisms involved in the neuropsychiatric complications of dementia. And with the clinician scientist training program, that's been able to fund him through the Garvey Institute and be able to secure also a NACC New Investigator Award that he's submitted his K Award to fund his next 5 years of his career. He is continuing to gather data on the immune system and its influence on neuropsychiatric manifestations of dementia. But he's going to talk today about the epidemiological data that served as the foundation for his current neuroimmunology work. In particular, he's going to talk about a blind spot that he's uncovered when assessing depression in this large cohort of patients, and how this has implications regarding the concept of depression in neurology and psychiatry and people with neurodegenerative disorders. It's my pleasure to present Dr. Daniel Fisher.
Dr. Schrift, thank you so much for that. And thanks for mentoring me through this project. As we kind of talked about, the overall arch of the project is to look at how depression might be mediated by certain inflammatory signals and signs in the peripheral bloodstream. However, before we can do that, we have to have a really good idea of the subjects and their symptoms. And so you guys will see how when you try to do this, it can be very difficult in the land of neurodegeneration, partially because we don't have a lot of psychiatrists here. So we'll be looking at this large cohort, and I'll be making a plug for why I really think that psychiatrists should be involved in this work and highlight those opportunities. I have no financial disclosures. I always start a lot of my talks the same way, where I mention that if you're a good clinician when they're thinking about dementia and neurodegenerative disease are thinking about cognitive things. And an even better clinician is thinking about other things that are related to sort of the nervous system that can happen, motor dysfunction, autonomic dysfunction, and tremor, to name a few. But the really great clinician knows that with most neurodegenerative diseases that result in dementia, you have a cornucopia of new onset neuropsychiatric symptoms. In Alzheimer's disease, over 90% of patients develop neuropsychiatric symptoms. These increase healthcare costs by probably an additional 30 to 50% per patient. They're distressing to caregivers, and they're often the reason for earlier institutionalization or loss of independence than even the cognitive abilities would allow for. And so this is a field where psychiatrists are really needed because the molecular and cellular underpinnings of these have been essentially unstudied. And today we're going to talk more about dysphoria and depression. So I'll take you guys through some of the methods that I did. And so the National Alzheimer's Coordinating Center, or NAC, has a very large data set of all the ADRCs, which are the Alzheimer's Disease Research Centers that track patients. And so UW has one. There's about 30 to 40 across the country. All the patients that come through there, and this is a sample of over 50,000 individuals with over 180,000 visit entries, go through something called the Uniform Data Set, where they gather over 1,000 different data points on their cognition, demographics, comorbidities, and then some of their neuropsychiatric symptoms, and they're followed yearly. For depression, they have 5 different ways of measuring depression and dysphoria. So the first is one called A5, which relates to the electronic medical record or the patient or informant report. And they ask, have you had a diagnosis of depression within the last 2 years, and is it active? There's then the NPIQ, which is a short form that asks, are you depressed? And it asks it on a scale from 0 to 3. And it's actually the informant that makes the answer. So they'll ask, does your loved one look depressed? And the informant will answer either 0 for no, or mild, moderate, severe being 1 through 3. There's then a clinician at the end of the clinical interview, of the research interview, that then gives a diagnosis. Then that goes to a panel at the end, where a whole panel makes a diagnosis of depression. And then finally, there's the Geriatric Depression Scale 15, which has the best sensitivity and specificity for scores above 6, indicating likely major depressive disorder in older adults. So within this NAC data set, there was no gold standard for major depressive disorder. Nobody was specifically going down the criteria list and giving that as a diagnosis. And because there was no gold standard, we instead had to look for other statistics that would give us an idea of how these different forms of diagnosing depression would work. So one of them is called the PPA, or the positive percentage agreement, which is basically when one test is positive, how likely is the other test to be positive? But the one that we settled on that we think is probably the most helpful is something called the Jacquard Index. Sounds very fancy, but all it really means is how often do both tests agree when either test is positive? And I'll give you a visual representation of what that might look like. It's a score from 0 to 1, 0 meaning no agreement and 1 meaning perfect agreement. So with a Jacquard index of 0.9, which is high, very close to 1, you can see that if you think about it in terms of Venn diagrams, you have very nice overlapping circles. And as the Jacquard index continues to go down, the overlap in that Venn diagram becomes less and less. So let's take a look at the actual data. So just in terms of prevalence estimates, if you use the cutoffs that I mentioned and the clinician and EMR diagnoses, you'll notice that the prevalences range from about 6% to 30%. Now, in a meta-analysis or systematic review, this might be considered normal because you'd be looking at a lot of different studies of different patients. But this is the same cohort measured 5 different ways, and you're getting wide spread in the prevalences. When we start to look at the Jacquard index, which is that level of agreement, what I hope you'll notice is that the numbers are relatively small overall and do not really approach 1. I also think that you'll notice that there's an elbow right to the left of the last 3 bars here. And so the difference is that the ones that are on the far right, these were all the clinical diagnoses, which agree with each other better than any of the objective screeners. And in fact, the worst Jacquard index, or the lowest, was actually for the Geriatric Depression Scale and the NPIQ, the only 2 measures that have been validated in any cohorts. One of the things I wanted to do was give you guys a context of what this looks like. And so the Geriatric Depression Scale has a lot of data on it. So in a meta-analysis of over 11,000 subjects, where the sensitivity was found to be 0.89 and the specificity of 0.77 and a prevalence of about 11.5%, if you compare the Geriatric Depression Scale to the gold standard, which was available in these studies, you'll notice that the Jacquard index is about 0.32. That's about twice as much as any other measure that is in the NAC data set in terms of agreement. So there's a huge problem with how people are defining depression, which makes it difficult then to decide how are you going to study these people for other features, including biochemical. What's interesting to me is that as I started to break down this data set by whether people were cognitively normal, MCI, or dementia, I had expected that those with dementia would have lower Jacquard indices. And in fact, I found the opposite. It was actually people who were cognitively normal where the Jacquard indices were lowest nearly across every single association, including ones that were both clinically derived from the panel or from the individual clinician, or from the objective screeners. To give you an idea for the Geriatric Depression Scale, even if we go and we subset these patients, none of these subset groups reach the same level for the gold standard of when the Geriatric Depression Scale is compared against major depressive disorder. So I talked with our clinical core and asked, well, what's going on here? How do we define depression. How do those clinicians make that decision? They responded, do they look depressed? I mean, this is really what they said. And I said, well, do we use DSM criteria or other clinical measures? Maybe the Olin 2003 criteria suggested by the NIH for depression and dementia? No, don't even consider them. Just, do I feel like they're depressed or not? Do other ADRCs also give the same opinion? Because remember, these are from a national data set. I don't know. This is kind of what they responded. What I think is important to glean from this data, though, and what's important for your practices, is that no matter what diagnostic scheme was used, all five agreed that as you go from cognitively normal to MCI to dementia, the amount of diagnoses of depression, whether it's an objective or more of a clinical gestalt screen, they all go up. And I think what else is important to keep in mind is that those who had met criteria for depression, they had an earlier onset of cognitive decline that was statistically significant, very statistically significant, based on age, where they were having cognitive decline almost 2.5 years earlier than those that didn't have depression, suggesting that continuing to study depression, both in terms of whether it can hasten cognitive decline or be a prodrome for cognitive decline, is important. So my conclusion, depression increases with the degree of cognitive impairment. Be thinking about it when you think about your older patients that may be having MCI or may even have dementia. Those with depression may have higher risk of converting to MCI or dementia later on in life. And unfortunately, the current measures that we're using are largely driven by non-psychiatrists and are largely finding to be ineffective in these data sets and may not be applied correctly. And this means that we really need more psychiatrists in this space. So thank you guys so much for letting me talk a little bit more about my project. We're very excited to start the biochemical analyses within hopefully the next month, as the samples should start to be coming in.
Thank you, Dr. Fisher. I have stopped my timer here, and we have 5 minutes left. We could have questions, we could have a discussion. Anybody who wants to pose a question for any of the presenters, any concluding comments, I could open it up to any participants here. If anybody wants to write in a question, or if anybody on the panel wants to ask each other questions, a lot of options. Thank you.
Well, Danny, that was a great talk. It would be interesting to look at people because now there's biomarkers for Alzheimer's disease, and there's soon to be hopefully serum biomarkers. It'd be great to look at the rate of depression in cognitively normal people who have positive Alzheimer's biomarkers. To see, is depression part of the prodrome of dementia, of Alzheimer's dementia?
Yeah,
we know you can get
Yeah.
positive biomarkers 15, 20 years before you become cognitively impaired.
Yeah, that would be fantastic. And I just don't know if in the NAC data set they do objective testing if they don't have some sort of cognitive impairment. But if they do, we can mine the data and see if there's a group that would give us that information. That'd be really cool.
Well, there's a study with giving anti-amyloid treatments to cognitively normal people with Alzheimer's biomarkers. So that it would be interesting to look at that.
Some people posted some questions to the chat, but I think they may only be viewable to the hosts and panelists. So maybe I could just quickly read one that came in from Rue Rouvert. Are there thoughts on adjusting CM procedures to include participants whose final goal might not be abstinence but reduction of use? And then Kevin Hallgren, our mentor, responded, good question, Rue. Folks could participate in the trial if they wanted to reduce their use short of abstinence or if they wanted complete abstinence. About 75% wanted abstinence. Rewards for substance tests required abstinence, only because there wasn't a good way to test if use was lowered short of an abstinence-based test. But there were incentives for doing other activities, including attending meetings with the recovery coach, doing CBT modules, doing self-assessment surveys, and so on.
Thank you.
And then Mac Black asked a question about spending cash on, as you mentioned, that being sort of a barrier to implementation clinics. And so, yeah, I agree. That definitely is a barrier, especially also like policies about clinics giving money to patients. So that's definitely something that has to be discussed. The original pilot study we looked at really was just looking at feasibility of implementation rather than efficacy. So, it would probably need to be studied more rigorously before we could like use it to inform negotiations with insurance, things like that. But, yeah.
Thanks, Adam.
Thank
And I'm sorry. I see that there was a question that Danny.
No, Jesse, go ahead. It's okay. Danny's typing.
Okay. Do you wanna just respond to that question, Danny?
Yeah, I think I'll respond verbally. So
Rather than typing.
there's a couple ways to look at it, but I'll try to be as succinct as possible. There have been both positive and negative associations with cognitive decline in antidepressant use, but that's obviously confounded by the indication. What I would say, though, is that there's a real difference between whether or not the depression is late onset versus early onset and has just persisted throughout life. In the large studies that have done that, the actual risk of having depression and later cognitive decline, if you have it earlier in life, seems to be highly attenuated. A lot of these cases are driven by people who have late onset depression or neuropsychiatric symptoms. And so those might be that prodrome as opposed to that risk factor. That being said, I am not aware of any study that's had a long enough arc to see if SSRIs or other antidepressants would slow the rate of cognitive decline.
Yeah, Danny, one thing, I realize I'm interrupting, but here we are at a final minute on a presentation that is emphasizing clinician scientists, and I feel the need and would like to mention Wayne Caton and one of his final studies, which was a longitudinal study looking at individuals with depression and diabetes and risk of dementia that was published in JAMA Psychiatry. And you might see if there's a treatment variable in there. I don't recall from memory, but that might be an interesting epi study to look at as well.
Yeah, for sure.
Well, I know we're out of time, but I just want to thank our mentors and our trainee presenters today. I hope that this is going to be an annual event to really showcase our clinician scientist training program projects, and want to thank the folks who joined today, and really impressive studies, really diverse, and looking forward to all the great things that you guys do in the coming years. Thank you so much.
Okay, well, thank you, everyone. A multiple presenter grand rounds often pushes the time limit, but I think we accomplished everybody getting to present their material and even fielding a few questions. So thank you, everyone. And the presentation there for today, and the grand round series for this academic year, and resume sometime in September. Thank you.